Yeah, and now going on to admissions, these are, this is really, it's intimidating to work up a new patient that you don't have a lot of information. You know, it's relatively easy to have a patient that's already admitted, already has a treatment plan. You already know what you're doing for this patient, and you're just kind of monitoring them until discharge on that treatment. It's different to see a patient in the emergency room and think, okay, what does this patient have? What studies do I need to confirm that this patient has this diagnosis, and what am I going to do to treat that patient? And so it can be tough in that sense, but it's really an important time to shine. You know, you can really impress people by, you know, you doing the one that gets, you interviewing the patient, you figuring out what the patient has, and you at least proposing how to treat this patient. And so think of a few steps towards admitting a new patient. Step one is gather information, and that starts with chart review. You know, read the ED notes, why are they here, review their vitals, labs, and imaging, check for prior hospitalizations or recent clinic visits. You know, and then, you know, see if anything's been done in the past for the same problem. If they've been hospitalized for the exact same problem in the past, you know, that information can be extremely helpful for determining what the treatment plan is for this patient with the same presentation, or you know, thinking about like prognosis and things of like, oh, maybe your condition is getting worse because you're more frequently requiring hospitalization and things like that. And then step two for this interviewing the new patient is step two is going to see the patient and interviewing them and gathering information directly from that patient. You know, even though there's a lot of information in the medical records, you know, what we like to say is trust but verify. You know, there's a lot of information, you know, vast majority of it's going to be accurate, but you will come across inaccuracies in the medical record. So, you know, a way to kind of approach the patient and tell them that you're going to ask them many of the same questions that they've already been asked. You can say something like, "Oh, I've reviewed your chart thoroughly, but I'd like to hear what's been going on directly from you. Can you tell me what brings you in today, from when it started up until now?" And that, you know, just an open-ended question like that will get most of the history that's needed. But if you need to follow up with other things, you can, you know, think of what comes to your mind about, you know, what you want to ask. But old charts, if you can't think of certain questions, is a good mnemonic. Like it stands for onset, location, duration, character, aggravating, relieving factors, timing, and severity. Other good questions to ask are typically like other symptoms they might be feeling or have experienced. Anything like this ever happened in the past? What makes them seek medical attention now? And then based on your differential diagnosis, you know, try to get more specific. You know, if you're thinking myocardial infarction versus gastric reflux, ask about anginal symptoms. You know, symptoms that could indicate more of myocardial infarction, like, you know, substernal, worse with exertion, better with rest, or ask questions about GI symptoms, like, you know, worse lying down, worse after eating, you know, and so, you know, you can pay special attention to those things that could differentiate different diagnoses on your differential, and you could figure out which one's more strongly supported. And so, you know, basically think of it as gathering two types of information. One is how you're describing the problem, and two is what evidence or information can you gather to support your diagnosis. And then after that, you know, thinking what information might you still be missing? Do you need to order other studies, and which ones? And then going into medications, medication allergies, past medical history, family history, Social history, what's their living situation like, any tobacco, alcohol, recreational drug use. And then go into physical exam. And, at the very minimum, listen to hearts, lungs, examine abdomen, examine their legs. But based on their symptoms, based on what you think is going on, use that to guide which physical exams you do, so that you can use the physical exams to help support or refute certain diagnoses. So after doing your history and physical exam with the patient, you'll typically ask about code status. And this is something that we ask everybody being admitted to the hospital. Even if we don't expect that they're at risk for cardiac arrest, we still want to clarify code status. And you don't want to assume full code on everybody, because CPR and resuscitation can sometimes cause more harm than good and may not be within the patient's goals of care. So a way to bring this up to the patients, especially if there's someone that you don't expect to be sick enough that their heart stops, you can ask, something we ask of everyone being admitted to the hospital is, if your heart should stop or if you should stop breathing, would you like us to perform chest compressions and put in a breathing tube to resuscitate you? And so in terms of after you've gathered all that information, you need to write the HPI and the history and physical. Typically start with a one-liner, that summarizes and describes the patient, describes their symptoms and illness developments. So start with a one-liner and then get into describing the symptoms and illness from when it started until the presentation to the emergency departments, and focus on symptoms that address your diagnosis and differential. And then get into what happens in the emergency department. Start with vitals, mention notable labs and imaging, and then include past history of this current medical issue. That can include prior hospitalizations for the same thing. And this HPI portion of the history and physical note, it can be kind of confusing. It's not super self-explanatory to include things like vitals and labs and imaging and past history in that kind of top portion of the note. But think of it as it's the history of present illness is what that is. And so having that information up front is really important for helping introduce the listener or the reader to what's been going on, and to start formulating what diagnoses could be at play here. And then go into describing past medical history, allergies, family history, social history, and continue with the rest of the note as you normally would. It'll include vitals, labs, imaging, and then you'll do your assessment and plan. And as a quick word on note writing, notes get a really bad rap because there's so much time that physicians spend at computers, but they're actually a really important communication and organization tool for your thoughts and for figuring out what's going on and how to treat it. So, really make sure to put the necessary time and effort into your notes. The residents and the attendings read what you write, maybe not every single note, but they're going to read what you write and make edits and corrections where they see fit. And these are permanent parts of the patient medical record. The whole care team, nursing, physical therapy, social work, everyone's going to be reading your notes that you write. And so it's important that you get them done before you leave the hospital so that the care plans are in place and people can go to your notes and understand what's happening and what plans are for the care of your patient. So to wrap things up, take home points, approach chart review in an organized way. so that you can do it efficiently and you don't miss important points. Have a tied up plan when you're talking with your patients that includes trajectory, issues, expectations, and discharge. Use notes to guide your presentations, present in a systematic order so you don't forget anything important. Assessment and plan, start with a global assessment and then go into mini assessment and plans for each problem. And then for admissions, remember there are two main types of information you want. So you want one, to describe the problem, and then two, what evidence or information can you gather to support your diagnosis. So good luck. Thanks for listening to the presentation. This is it can be a fun year. You're doing you have a lot more independent responsibilities, and I think make the most out of it. If for anyone that was interested in this presentation and interested in listening to more about medical education and medicine, these are some really good podcasts that I would recommend.